Thank you for the opportunity to address students, faculty, house officers, and so on this important issue of ethical issues in international health research. It gives me particular pleasure because I first came to Nepal in 1967, and one of the first places where we talked about and reported on our research on oral rehydration therapy was right here in Nepal, in a talk that I gave at the Bir Hospital in about 1968, I think it was. So let's proceed with today's discussion. This is a picture of the trial that was held following World War II of the Nazi doctors and others who carried out really inhuman studies during their reign of terror in Germany. This was really the origin of our contemporary interest in research ethics because of the abuses that were carried out by so many of these people. For example, and this is hard to believe, but they wanted to know how long someone could live in freezing water because they were concerned that their pilots would be shot down over the freezing waters of the Arctic Ocean. And so they put prisoners and others in freezing water until they died, and simply recorded their body temperatures, how long they could last, and so on. So there were many of these kinds of studies, and in fact, there are a number of abuses that occurred in the 20th century, including those of the Nazis, the Japanese-style warfare experiments that were carried out in China against primarily Chinese through Unit 731, post-war power abuses that occurred in the U.S. With Tuskegee experiments, the USSR on poison experiments carried out by the KGB, and a syphilis study carried out in Guatemala by U.S. investigators. The abstraction from all of this is that the history of research abuse is really the history of racism, class injustice, and other forms of bias and discrimination. All of the individuals who were subjects in these studies were people who were viewed as less than human, as people who were considered enemies of the state, people who were seen as less than normal individuals who were in these countries. So that the ethical starting point is not just the individual versus society, but equity and human rights. This is what underpins the whole history of research abuse. The fundamental principles that are that every individual, no matter who they are, matters equally, regardless of their position, their ability, or their wealth. If all of you in this room were sitting here with no garments on, we wouldn't know who is who. We wouldn't know who is rich, who is poor, who is high, who is low. We are all equal, and that is the value that we must have when we consider doing research. There are three basic principles: respect for persons, beneficence, which means do good, and justice, which means the collection and treating everybody equal. This is from a report called the Belmont Report, which was initiated in the United States. But I'm going to spend most of my time on this issue. These were principles that were set up by a group at our NIH on principles of what makes clinical research in lower and middle income countries ethical. So I'm going to cover each of these particular topics. The first one is scientific validity. If something is not scientifically valid, that is, the sample size is too small, the method we use is incorrect, by definition, that study is unethical because you're conducting work for which you cannot find an answer. So scientific validity is absolutely critical. You need to solve local health problems. You can't deny people services so that you can see what the value of other services are. That is unethical. The study should be doable within the scientific skills that you have. If you don't have those, then there's certain studies that you cannot conduct. So scientific validity is absolutely critical. How do we select the population that we're going to study? It should be fair. We should minimize risk. We should develop collaboration between those we are doing research on and ourselves. Be it a community nearby or ourselves, we should try to develop collaborative relationships and particularly protect vulnerable populations. Who are those? Children, people who are mentally challenged. These are vulnerable populations, and we must take particular care in protecting these individuals. The risk-benefit ratio, that is the benefit that could come against the risk that is applied, must be heavily weighted towards benefit. And for at-risk populations like children, that is absolutely critical. We should be able to also protect the community. We often think of research ethics as only protecting the person. We need to also protect the community, particularly if the community is vulnerable for certain things. I remember many years ago when I was in India, an old man complained about the following study. Somebody had done a study looking at the prevalence of HIV in various communities. And there were some communities where the young girls would go to work in the brothels on Falkland Road in Mumbai. And so this person did a sero-survey. He was blinded, so he didn't know who was positive and who was negative. He just knew the population group. And then he went to a meeting and he announced his findings. And he said, Dulakil has a lot of HIV. So why was this old man very upset? He said, who's going to marry our daughters now? Who's going to come to our community? You have stigmatized us, not as individuals, but as a community. And countries have been stigmatized. So we must be very careful in looking at the risk-benefit ratio. Independent review. Independent review is like your ethical review board. It reviews the studies to determine whether or not there are ethical principles that have been followed. And if not, they must go back to the investigator and correct these issues. Now, why do we have an independent review board? Why not just let the researcher go out and do what they want? Well, first of all, the public would not trust us. They would say, oh, you're just here to make money. You're just here to exploit us. You're taking our blood so that you can sell it. All sorts of things of that nature. So it gives public accountability and ensures proper ethics and study design. It's independent, and it should be transparent. So people should know, should be able to know what is going on with the Ethical Review Committee. It should not be determined by just the chairman or the head of the hospital. It should be transparent so we know what kind of discussion has taken place. When you get grants from international institutions, they may have their own ethical review board. So you may have one and they may have one because they're giving you the money. How do we deal with situations where one board disagrees with another? We've never really worked that out very well, except that we negotiate back and forth. But oftentimes there are multiple review boards from the donor, from the recipient, or there may be many institutions involved in the study, not just a single one. What about consent? That is the consent that the individual says, I agree to participate in the study. So what do you have to have there? You have to, the person should know, what is the study? What are the goals? And then lastly, and this is extremely important for your institution, what is the collaborative relationship? Is somebody coming here just to collect specimens and then running away and doing the studies at their own universities and maybe not even telling you the results? Or is this a collaboration? Will you, as an institution, benefit? Will some people be trained? Will you participate in writing the study up? Will you be involved with the outside group in terms of determining what the study should be? Collaboration. Many, many years ago, that was not the case. People would fly in, they'd take some specimens, they fly out, and maybe, or maybe not, you would read about it. That is not acceptable. It must be collaborative, mutual respect, fair benefits, fair distribution of the rewards of research. And there are rewards. Rewards of prestige, you get promoted. Rewards of maybe monetary rewards, and so on. All of these are critical in developing collaborative partnerships. What happens when the research is over? Should there be continued provision of higher level of health care? What if you set up a study, one group gets a very high level of care and the other gets standard care? What happens if you show that this high level works? Is that it? Finished? You run away? Or do you make sure that in your study design you build in the possibility of developing better health care? Who should benefit for research beyond the direct participants, and for how long? Let us say you have a vaccine. How long should that vaccine be given? These are all rather important issues. What about long-term safety? We give vaccines, but sometimes we don't see impacts or drugs for 10, 20, 30 years later. How do we follow up on these individuals? What should we do to ensure that there is no ill effects after a time? And if there are complications, who's going to pay for them? What responsibilities do research sponsors have to contribute to the development of national expertise? Going back to collaboration, if people are coming from the United States, Germany, or Norway, wherever, a wealthier institution, and do collaborative research with Kathmandu University, the question is, what skills will you develop in the process of conducting this research? These are all ethical issues. Let me deal with two types of research that are now becoming increasingly important. One of these is implementation research. Implementation research means I take some idea and I try to then expand it into the community. In my case, it was oral rehydration therapy. So we showed that it worked in the hospital. It's very clear that it worked. People were in electrolyte balance. It helped bring up their state of hydration. But the real challenge was, how do we take that out to the community? Because there were no doctors out there. There were no nurses. There was no IV. So the implementation of how did we implement this in the community was critical to its widespread use. It's multidisciplinary. It oftentimes involves anthropologists, sociologists, people that as medical doctors we're not used to working with, and yet they're critical to understanding implementation research. We need to focus on the process and the outcome that should lead to the particular health gains, whether it's better birthing practices, as we saw in the film. Many of those birthing practices will have to be carried out in the home, not in the clinic. People living way beyond where clinics are found. How will we ensure that the delivery of a child with midwives is safe? Some of the ethical considerations are, what is the engagement of the stakeholders, people who are going to benefit? What is the commitment to sustainability? So we show that it works. Do we then pack up our bags and leave, or do we continue on with that particular effort? The acceptability of local standards. All of these ethical considerations need to be thought about. And lastly, and this has of course been in the news lately, is what about ethical issues raised by the emergence of new infectious diseases? Right now we're dealing with Ebola in parts of Africa. This is a new disease. We are just learning the epidemiology. So when you deal with a new disease, you have no vaccine. You have no drugs to treat it. So you are dealt with certain ethical dilemmas. Who should receive a tested vaccine? Should it be the health workers? Many of the first people who died in these epidemics were health workers. How do you deal with an outbreak where you don't know the basic epidemiology? You don't know what criteria, who should get a test vaccine, who should receive that vaccine? Research that will benefit not only our own populations, but hopefully the global community. So thank you very much.